This is a normal venogram of the veins of the legs. Note that we only see the deep veins because a tourniquet is often applied at the level of the ankles to divert the flow to the deep venous system. This is a normal venogram of the thighs, and note the presence of valves in the femoral vein, and note also the filling of the left saphenous. The external iliac and common iliac veins, as well as inferior vena cava, may be visualized following the injection of a vein in the dorsal aspect of the foot, but occasionally we may have to inject directly the femoral vein, as was done in this case, and note that there is a normal visualization of the common iliac veins and of the inferior vena cava. This patient had extensive occlusion of the veins of the lower extremities. Note the flow diversion towards superficial veins, the lack of filling of the deep veins, and some filling defects were also present in some of. This is another patient with extensive occlusion of the veins of the thighs bilaterally. Note the tortuosity of some collateral channels and filling of superficial veins. A venogram in the right posterior oblique projection shows extensive filling defects in the common iliac veins and in the distal part of the inferior vena cava. This is another example of complete occlusion of the left common iliac vein and flow diversion towards the ascending lumbar vein. Here is a case that shows also a technical error. The tip of the cannula should be below the iliopectineal line at the level of the femoral triangle in the thigh, not at the level of the pelvis. This is a patient with a carcinoma of the bladder who developed phlebothrombosis. Note the occlusion of the iliac veins, flow diversion to the perivertebral venous plexus, and poor visualization of the inferior vena cava. When a patient shows edema of one lower extremity and there are no signs of phlebothrombosis clinically of the lower extremities, one must suspect the possibility of a pelvic malignancy occluding deep veins in the iliac region or occlusion of the inferior vena cava, secondary to a pelvic malignancy. It could be a carcinoma of the bladder, a gynecological tumor, carcinoma of the prostate, etc. Here we can see extensive filling defects in the iliac veins and inferior vena cava. This is an ominous sign and may represent impending production of a massive embolus. So such a patient should be treated immediately with the insertion of a cable filter, or if the patient is going to have surgery, the inferior vena cava should be ligated distal to the renal veins. If the patient is not to have surgery, anticoagulation also should be used immediately, or some sort of a fibrinolytic product to try to dissolve extensive thrombi in the inferior vena cava and pelvis. This is a patient who had a successful ligation of the inferior vena cava distal to the entrance of the renal veins, and a few months later had recurrent pulmonary emboli. A study of the veins revealed patency of the inferior vena cava above the site of ligation, but note tremendously enlarged ascending lumbar veins and perivertebral venous plexus. If at the time of surgery the ascending lumbar vein is not ligated, emboli arising from the veins of the lower extremities can find a path towards the lung via shunting towards the ascending lumbar vein and the perivertebral venous plexus, which is devoid of valves. So it is possible to reconstitute flow from the lower extremities to the inferior vena cava or even to the superior vena cava via the expansion of these potential collateral pathways.